thyroid cancer management is divided into investigations and treatment. Investigation, as in my prior, I would say my prior teaching videos, I stressed on the importance of thyroid function test, ultrasound neck, ultrasound FNAC of the nodule, CT scan plus minus MRI, PET CT and radioiodine scan. I would not like to concentrate for this particular teaching session on the imaging modalities or investigative modalities. I would like to more harp on a treatment modalities. Treatment will predominantly consist of surgery, radioiodine treatment. Third, radiotherapy. Fourth, we have a chemotherapy or what we call as a use of TKIs. TKIs are tyrosine kinase inhibitors. Surgery is a mainstay of treatment for thyroid cancers. Surgery in the form of near total thyroidectomy or total thyroidectomy for all the nodules which are more than 4 centimeters, which are having neck node metastasis, which is having central lymph node metastasis, aggressive histology, history of irradiation, family history. So taking into account the high risk features, the surgery indicated today is near total or total thyroidectomy. I am Dr. Snehal Shah. I am a head and neck cancer surgeon. I am also a robotic thyroid surgeon. Now, apart from near total, for those nodules which are less than 4 centimeters, we would try and do a hemithyroidectomy and try. So less is more nowadays in thyroid cancer because it's indolent. So the lesser we do, the more benefit is what we give to the patient. So important dictum, less is more in thyroid cancer. Now, apart from hemithyroidectomy, which is a basic minimum surgery, there is no role today for lobectomy or a subtotal thyroidectomy. Now, subtotal is where we leave a part of thyroid tissue on both sides in the tracheoesophageal groove. There is no role for subtotal thyroidectomy. There is no role for lobectomy. I would say that hemithyroidectomy is a minimum possible surgical management for this particular kind of patient. But if the patient is showing a neck node metastasis in the lateral compartment, I would also convert this hemi into a total thyroidectomy. Now, one is surgery. Surgery, if the patient has got various high risk features. For example, patient has got aggressive histology, neck node metastasis, patient has also got distant metastasis, then or there is high chance of disease coming back. The other modality which is used is radioiodine. Adjuvant radioiodine is given. So radioiodine can be divided into empirical radioiodine, adjuvant radioiodine. Empirical radioiodine treatment is given for those patients which are comparatively low risk, maybe not T1, T2 or maybe T1, T2 but with no neck node metastasis or with no central compartment nodes. You might want to give empirical RAI. However, the current data suggests that you can just observe, may not give what I say is the remnant radioiodine for remnant ablation. The second is adjuvant RAI, where there is a high risk of tumor coming back. For example, intermediate or high risk cases, you would like to give adjuvant RAI. And third modality which I would like to state is the radiation. Radiation for those where the tumor is either poorly differentiated, anaplastic, aggressive histology, where the tumor, where the morbidity of thyroid surgery is much more, you would like to give a radiotherapy, or you have left behind a gross disease. So patient with a gross disease, R2 resection, where you have left behind the chunk of disease, you would still like to radiate it. The fourth indication, the treatment is modality is TKI. TKI only if the patient has got impending complication. Actually, those patients who have got distant metastasis or a recurrent residual disease for which surgery is not amenable, but the patient is getting symptomatic. For that, you need to give a tyrosine kinase inhibitor. To know more about the indications of each of them, please visit my site